So the next paper is going to be given by Phillip Webster from Joburg, and it's the fractures of the proximal and distal humerus.
I'm just going to very briefly go through just two aspects of proximal humeral fractures. Discussed it with Leon before, and really what I want to do is to bring in the topic of osteoporosis, because the talk yesterday, I think, showed that we have some inadequacies in our understanding of osteoporosis, as I have been trying to operate this machine. Where does the control? Okay, so just briefly on the classification, there's a number of classification methods that Leon has alluded to, but the importance is that what we want to do is assess, first of all, vascularity to the head, and secondly, the stability of the fracture fragments after we do it. And we need to assess the anterior circumflex humeral artery and the posterior circumflex artery. And then we need to look at the periosteal and capsular sleeve, the amount of lateral displacement of the head, if that's more than 5 millimeters, and then, as described, the medial metaphyseal calcar extension of less than 8 millimeters indicates that you have less chance of any vascularity to the head. And this vascularity of the humeral head is what you really need to be aiming for, because that is what will determine whether your fixation or replacement will work. So if we look at patients with osteoporosis, and the clinical implication of it is we really are presented with a complex fracture occurring in an aging population that requires early return to function with avascular bone that's incapable of holding the fixation. And this leads to obvious conundrum in treatment. And as I say, we need to assess, first of all, whether we're going to do head-preserving surgery or prosthetic replacement. We're going to assess the bone quality, and we're going to assess the vascularity of the humeral head, and then provide for adequate replacement in case of failure. But we must aim to have one operation that's going to last these patients for their time. So if we look at osteoporosis, it's the most common metabolic disease in the Western world, and it's recognized as a major cause of disability and mortality in older men and women. It's been described as a silent epidemic that manifests as fragility fractures of the distal radius, the proximal femur, the spine, and the proximal humerus. Upper extremity fractures account for 1/3 of the total incidence of fractures in the elderly and can lead to a permanent move to a nursing home in 6% of these patients. The risk factors for proximal humeral fractures are primarily associated with low mineral density and an increased risk of falls. And most commonly, the mechanism for an osteoporotic fracture is a simple fall from a standing height. If the patient has a more traumatic incident, then that's a less likely indicator of osteoporosis. The incidence of fractures is 2.6 times greater with osteoporosis, and there's a 3-fold incidence of osteoporotic fractures in the last 30 years, and we expect another 3-fold incidence of fractures increase in them in the next 30 years. And if you look at your bone mineral density, it shows a direct correlation to the pull-out strength of your fixation and has a major effect on the biomechanical behavior of the bone implant construct. So, when do we do a fracture fragility workup? If we have a low energy fracture of the proximal humerus, it's an indicator of underlying osteoporosis. Proximal humeral fractures correlate more reliably with bone fragility than other fractures, and they are independent predictors of subsequent hip fractures. And in fact, an individual with a proximal humeral fracture is 5 times more likely to have a hip fracture within 1 year of the injury. So all patients with low-impact proximal humeral fractures must be referred on and have a fracture fragility workup for osteoporosis. We do you'll know this, we've been through it yesterday. You must have a skeletal history and risk factor assessments, do a physical examination, a DEXA scan, and then look at treatment and prevention. But we can quantify osteoporosis at the time of surgery. So you can't send your patients who have fractures, all of them, for DEXA scans and densitometry scans. So if you look at Bloom and Tingott, they showed a direct correlation of bone mineral density with the proximal humeral cortical thickness. And what you do is you measure 2 sections across the humerus and you start at the junction of the humerus where it becomes parallel. So you see, there's the flare, that's your first point, and your second point is 2 centimeters below that. And if you measure the mean thickness of the cortex at those points and those points, if it's less than 4 millimeters in thickness, the patient has osteoporosis. There's a more than 99% correlation of osteoporosis with this. And this is based on a plain X-ray, which all of the patients will have. If you look at them, Hep and others, 2009, they defined the cortical index matched with 113% of proximal humeral fractures. And they found that the fracture group showed significantly lower cortical incidence and a non-significant correlation with failure of fixation of locked plates. So there is a lot of evidence to show that we can do this, and it certainly gives us a very good idea. It's not 100% clinically correlated as yet. Then if we look at valgus impaction fractures, a lot of work was done by Robinson and them, and these are distinguished from other fractures by the unique fracture pattern of the valgus fracture dislocation as well as the impaction of the head in 3-part and 4-part fractures, and they generally have a much more benign outcome and a low incidence of avascular necrosis. So in a stage 1, we have a medial periosteal hinge. Stage 2, there's lateral translation of the head. And in stage 3, you get a denuded head, which has a high risk of avascular necrosis. This is a treatment algorithm, which I'll go through a little bit now. And what we need to do is in these patients is work out whether we have a sufficient head to take fixation, or whether we require, and what type of fracture augmentation we require in the osteoporotic group of patients. So options for treatment are locking plates with augmentation of the tuberosities. We can have plates with medial column support screws. We can have polyaxial locking screws, intramedullary fixation, or percutaneous fixation. But all of these methods of fixation without augmentation generally tend to fail into varus, impaction, and subsequent avascular necrosis. So Namdari did a study in 2012. We did a meta-analysis of fracture augmentation after proximal humeral fractures, and he compared the results of intramedullary fibular strut grafts with calcium phosphate and cement, as well as iliac crest bone. And what he found is that if you look at the fibular strut graft, it's actually been popularized quite a lot in the past. First introduced by Gilles Valche in 1996, where he did the quite well-known gap study model. Bayard and others showed that you have significantly less displacement with the fibular strut graft. Chow and others showed the same, no varus collapse of the fibular graft. Navaza, the retrospective study at 75 weeks of 38 patients, no screw out penetration and no reduction lost in the fracture. And Richard and Hines showed no difference in it. One of the important factors of this is not a vascularized graft, and it's not a difficult procedure to do. All you do is most of the hospitals have fibulas from the bone bank, and you take your fibula, which is normally a length of about 9 or 10 centimeters, and you simply open the humeral head where the fracture is, you put it down the shaft. Because they're osteoporotic, it tends to impact at about the junction of the proximal third of the humerus, and then you leave 2 centimeters of it proud over the fracture site, and you literally balance the humeral head onto that fracture. And once you balance that and you hold it so with some slight medial tension on it, your fracture reduces, and it becomes easy then to put your plate on because everything is held in place. So it's not a complicated procedure at all. If you look at calcium phosphate, the reason we use this is that it resembles the bone mineral phase of bone. It fills the void left after a valgus collapse. And again, there's studies to show that there's significant decrease of the motion there. And overall, you can expect a 3 times increase in strength and loss of reduction if you use this. Iliac crest graft is a tricortical graft placed in the fracture progression, and again after 4 months they found that there was good results with this. So what I believe you should do, and there's no great clinical evidence to show this, but I think what you need to do is you need to first decide on whether you're going to fix these fragments or replace them. The second thing is that if you're going to fix it, then you must assess the medial cortex. And if the medial cortex is intact and their cortical thickness is greater than 4 millimeters, then you don't need any augmentation at all. This patient doesn't have significant osteoporosis. If your medial cortex is intact but you have less than 4 millimeters of fixation, then you need to have fixation plus calcium phosphate or cancellous bone grafting. If your medial cortex is not intact, then you must use a fibular strut graft. And if you do this, you should end up with better results and more stable fixation. Leon's been through the hemiarthroplasty. I'm not going to go through that. And so I think that these fractures, we must remember, they're common. They can have a significant effect on the patient's quality of life, and each fracture must be assessed on its own. There's no one treatment for every patient, but we must provide one operation to look after them. So the current problems are failure of fixation, avascular necrosis, and tubulosity failure. And if we assess the patients, we assess their osteoporotic risk, we assess the vascularity of the head, and then we can, I think, get good results by following these principles. Thank you.
Thanks very much, Philip, and thanks to the other speakers. We're going to cut the discussion session short because we're running a little bit late.
One more talk.
Oh, sorry, sorry, Philip.
If that's okay.
Okay.